Hi, I'm Dr. John Lenahan. I'm a robotic GYN surgeon from Seattle, Washington, currently working with Mimic Technologies. And we're going to have a discussion today with two surgeons from Australia, Professor Anthony Costello and his son Daniel Costello. Professor Costello is a world-renowned educator in robotic surgery. He's a lead urology surgeon in Australia, and he's traveled and lectured around the world on teaching not only urologic procedures, but robotic surgery in general. His son Daniel is a graduate urology practicing surgeon as well, who's also very interested in simulation and training. We're going to start with Professor Costello and ask him a little bit about the landscape of robotic surgery in Australia and where he sees this going, especially with his center being developed. His center is AMRA, A-M-R-A, which is the Australian Medical Robotics Academy. It will be a wonderful center to highlight robotic surgery training throughout all of Southeast Asia. So let's start with Professor Costello.
What's happened in Australia, which is unfortunate, is that most of the robots in Australia are concentrated in private hospitals, and the teaching hospitals where surgeons are trained are what's called public hospitals. So 50% of the population access the public hospitals. So the training is done in public hospitals. So a lot of our trainees are not getting access to consult time and robotic training. So there's been no College of Surgeons mandated training pathway for robotics. It's all very haphazard.
Well, thank you, Professor Costello. Can you explain to us a little bit about your approach to surgical training in general, and in particular, robotic surgical training that you're going to be employing there at the AMRA Center?
What I decided to do was build a contemporary laboratory which encompassed all the different facets I believe are needed in robotic surgical education, starting with the online. So a fairly solid component of online education before the student actually comes to the laboratory. Once they've completed some quizzes from their online learning system, then we will take them into the simulation lab and we'll put them through between 20 and 40 hours of exercises on the simulators using mimic simulators through graduated exercise to competency. And once they're competent, we feel, in the simulator lab, and they can come and access. We've made it open access so they can do it after hours because residents are time poor. They can come weekends and after work and use our simulators and log their progression to proficiency on the M-score system in the cloud. Once they've done that, we have a system of synthetic human organ models, which are made by Amit Ghazi in Rochester. We're at the present validating a 200 cohort or 200 model of radical prostatectomy, where we take robot-naive surgical trainees after their simulation exercises and put them through 10 synthetic organ model surgeries, which are scored. They're assessed by one of our experts, and we compare that learning to surgeons who have had between 20 and 50 robotic cases without any of the AMRA type preparation, and see whether we can speed up that training to get them equivalent in proficiency using the 10 model approach with pre-simulation and online learning. And then once they've done that, we take them to the operating room and then we let them do their cases, and then we would score those cases and see what level of proficiency there were. So there are 4 pillars of an education system. So it's not a single event episode. We work with the vendors only about the mechanics of the system. So we work, say, with Intuitive, and they will give us all the information and specs on how to use their technology. And that's where they have a role. But in terms of teaching surgeons how to operate, I think that's the mandate of surgical educators, very expert surgeons who will take time away from the operating room to use what we call the aviation method. We're working with Qantas and using their learning management IP, which has got human factors, safety, all those ways of training which are not pedagogic, they're not lash-based, they're gentle and reassuring and affirming rather than belting around the ears. So we believe that it's the time now for a profound change in our approach to education. I think we've convinced our college to allow us to develop this pathway, and then once we'll seek some sort of accreditation for that pathway of learning surgery, and it will be across all the different disciplines, so gynecology, colorectal, general surgery, urology, and then eventually to ENT and thoracics and whatever else.
Thank you, Professor Costello. Now, turning to Daniel. Daniel, what do you see as the role of your center in the spreading of robotic training throughout Australia and Southeast Asia? Where do you think this is going?
The environment of robotic surgery in Australia is changing with the potential introduction of new robotic systems into Australia, and we hope further penetration into the public health system where our residents are trained. Currently, robotic surgery has been taught at the fellowship level in Australia, and the Costello Fellowship was the first robotic fellowship in Australia, starting in Melbourne, and there's been a number of well-known international robotic surgeons trained in that method, which is probably the Halstead method that's one-on-one with Professor Costello breathing down their neck, and very intensive, immersive experience, but gets them to a point that is proficient, but probably quite a grueling process. So I've been going through a process in my Master of Surgery at the University of Melbourne, which is focusing on robotic surgery education, to extract the knowledge from those master robotic surgeons in Melbourne, who we've assembled onto our faculty here at AMRA, and extracting that knowledge and those lessons that they can deliver and putting it into an accessible format. So we're now utilising new education technology and methods to broaden the access to those lessons. So we're beginning with theory by capturing surgical video and online learning with lectures from experts, and then progressing the students through virtual reality simulation, where they can come and work in our AMRA lab using those mimic machines and have tailored scoring and then tailored curriculum to meet different learning needs of our students. So we adapt the training to the individual student rather than the student just following a prescribed method, so that we think that training to proficiency is a much more efficient way of training rather than training to time, because surgical training is very long, takes 5 or 6 years just to get your basic surgical qualification here, and then fellows are then doing 1 to 2 years in robotics. So we want to integrate this way of training all the way through their education. And then by using the models, we can have the surgeons train multiple events on the same operation with a standardized set of steps for an operation, and then review that by video in their own home, which I think in COVID-19, using online learning and online review systems is more important because it's harder to bring people together that way. And then that method of training continues into the live surgery setting, where we again use video review and have experts scoring them, which can be done remotely.
Yeah, your experience is very similar to what happened in the United States with, initially the robots were used by community surgeons, and then it moved into academics with fellowships, and then it's just now starting to get into residents, and everybody's following the Halstedian model. So getting into where we use simulation, where we use hydrogel models, where we use video review, and putting together the psychomotor with the cognitive before they get in the OR, I think is going to be good for all of us. So I know AMRA was all set to take off and run big opening ceremonies. How's COVID slowing that down? What are your plans now for the next year or year and a half until we get out of this pandemic?
Yeah, unfortunately, Melbourne's gone back into a temporary lockdown, and so we were sort of set to launch in August, but we're currently under 6 weeks of stay-at-home orders. But we've taken the opportunity in COVID to do a lot of the preparation for these courses and refine our material and work closely with the team at Mimic to adjust our curriculum on the simulators. And I think it's it hasn't been wasted time for us at all. And I think it's going to be really exciting once we get some students in here, because we're really pleased with what we've been able to put together, and the team that we've assembled across. For our early courses, we're going to have gynecology, colorectal, general surgery, and urology as our focus. And there are a lot of very eager surgical students out there who've been a bit starved of opportunity in surgery this year, live cases and education, because a lot of operating has been reduced down to 65%. So we know there's a really big demand out there. So we'll have people banging down the door once we're allowed to open.
Who do you expect to come as students? Are these all going to be registrars? Is it going to be foreign, fully trained surgeons, or what's your target audience?
Yeah, so the way that the AMRA model works is that there's a foundations of robotics course, which is really the entry point for any robot naive surgeon. So regardless of where they are in their training pathway. So that would include residents or registrars who are on programs, and those that are applying to do surgical training, as well as surgeons who might have had experience in open and laparoscopic surgery, but not in robotics. So they would all come through the foundations course and learn the buttonology from the vendors, some of the robot surgery theory, and then some surgical tips to get them started safely in robotics and learn those psychomotor skills on the simulators. And after that, we put them into their craft group. So they would then break into specialty focused courses and then progress all the way through to sort of masterclass level, where they're doing synthetic organ procedures and then having reviews in their live surgery. So it's an interesting point in robotics for Australia, because we're going through a transition point where I think in a few years we'll see that everyone will funnel through this pathway from the beginning of their training. But at the moment, we're going to have a mix of people who will be quite experienced surgeons, but with limited access to robotics. So they'll come and mix in with the residents, I think. Yeah.
So your plan is to have people go through the entire course and become certified, if you will, to go out with some, I'm sure, with some proctoring and mentoring to start. How long do you think this will take? And are you considering looking at innate ability of these students?
Yeah, well, in my my Master of Surgery at University of Melbourne, I've included a study on innate ability, because I've seen the great work that Moglia did in Italy with medical students, looking at those that have a high innate ability for robotic surgery. I think it was consistently around 6% in his two groups, and then those that have poor natural ability for robotics was around 11% both studies, and that large average cohort in between. So what we're interested in looking at is assessing surgical aptitude in robotics amongst surgical residents, so those that have selected to go down a surgical pathway. And it'll be interesting to see what that skill distribution is, and whether we have a narrower distribution or time will tell. But we're actively recruiting residents and registrars at the moment who are robot naive. And so this is potentially something that could be used for selection for hospitals, and also to tailor curriculum for those rapid adapters who have a high aptitude for robotics, and then we can potentially tailor training to meet their needs, rather than this very long, drawn-out process of surgical training at the moment. We could customize.
Well, that was very, very interesting. We here in the United States agree that the real future of robotic surgery training is training surgeons to proficiency on simulation prior to allowing them to go into the OR to start working on live patients. And it looks like you're embracing that technology and moving this forward. So we applaud your efforts and look forward to more news about your wonderful center. And we actually all look forward to visiting it at some point. Thanks again for participating today.